Hi, everyone. It's Dr. K, and we are in week 5, as you can see on your screen. I'm going to spend the next few moments going through cardiovascular, pulmonary, breast, and chest. And we're going to talk a little bit about head to toe as well, since that is going on in week 5. So you can see your reading assignments for this week are thorax and lungs, the cardiovascular system, peripheral vascular system, as well as breast and axilla, and those are all in your Bates textbook. Other important reminders for the week are making sure you're completing your course activities. And so those entail your shadow health modules. So you do have 4 this week. You have your concept labs, which are a little bit shorter for respiratory and cardiovascular. And then you have the actual respiratory and cardiovascular modules themselves. For Q-Banks this week, you have cardiovascular and respiratory just along with your reading as well. So again, remember, you can always take those in tutor mode or exam mode. You need to do a minimum of 40 questions and submit your best attempt. Must get an 84% or higher for us to be able to count that grade. And then we're going to spend the bulk of this session talking about cardiovascular and pulmonary in terms of your videos and the rubrics and your 3P APEA scheduling. So that should be coming out this week from Dr. O, as that occurs in week 6 through week 7. So you will be getting an email on how to schedule and what you should expect when it comes to 3P APEA. So with your head to toe, I'm going to speak briefly about this, since you can see in the week 2 session a very thorough review of your head to toe. So in order to complete that assignment, you must have attended immersion. So you have your lab coat and your supplies. You've reviewed that tutorial in week 2. And then when it comes to the Dropbox that you'll submit, you're going to have your best practice checklist, your patient consent, which is going to be a written consent, unlike your other weekly videos, a government issued ID or USU badge, and then your YouTube link. So there's going to be 4 things that are going into that Dropbox. Please make absolutely sure that you do not have any photo ID on you in your video, as if YouTube sees that, they will go ahead and take that video down and flag it. So you will not be able to use that video. We cannot accept videos that are sent in a WMV or .mov file. So please make sure you do not have your photo ID in your video for the purposes of your head to toe. So now we're going to talk about cardiovascular. And so, of course, we start with a review of the anatomy and where are we seeing arterial circulation. And so on the left-hand side of your screen, you can see all of the arteries and how those are filtering through the body to the peripheral system, as well as a good depiction of the aorta and how that factors into the heart. Then we think about what happens with our patients that have blockages and when we're trying to figure out what's going on with the patient. And so that usually occurs by cardiac catheterization for the most thorough view. And you can see the site on the left-hand side through the right femoral groin and catheterized into the heart. And so you will see exactly what that looks like with a stent being placed, and pacemaker implantation also if there is irregularity in the rhythm, and what that looks like from the terms of anatomy. When we talk about EKG leads or ECG lead placement, your placement will absolutely dictate the findings that you are going to have on your rhythm strip. So we often see 3 lead, we see 5 lead, but when we are talking about a 12 lead EKG, we are talking about getting the best snapshot of all of the areas of the heart. So they are beneficial in terms of they're inexpensive, they are non-invasive for your patient, and they provide a real-time electrical impulse snapshot. So you can see lead placement here, as well as with those limb leads. And then the electrical system of the heart, which stems from the sinoatrial node down to the AV node, and then the Purkinje fibers and the left and right bundle branches of the heart. Now with rhythm detection, how do we know if the patient is in a sinus rhythm? Oftentimes as nurses, we were told anytime it's a sinus rhythm, it's a regular rate and there's a QRS that follows. But that doesn't always apply when we consider things like heart blocks or ectopic beats. You can have a P wave without a following QRS. So in order to know if a patient is truly in a sinus rhythm, in looking at lead 2 on the EKG, with the P wave being positive, and then an AVR with the P wave having a negative deflection, that is the best way to know if the patient is truly in a sinus rhythm with the electrical impulses. And again, that goes back to the anatomy of the patient, and you can see just an ECG on the bottom of your screen there. When it comes to rates and regularity, this is taken directly from your Bates book. And so we are looking at, is the patient in a regular or irregular rhythm? And what is really making the difference with that? Is it the rate? Is the pattern of regularity? And then when we talk about the heart rates themselves, is it too slow? Is it too fast? Or is it within the expected range? When it comes to the pattern, we're looking at, is it a sinus rhythm? Is it an irregular rhythm like A flutter? And so you can see that on your screen. Again, that's from table 16.1 of your Bates book. So what does chest pain feel like to your patient? Every patient is going to have a different description. So get very familiar with those words of throbbing, crushing, burning, tight. And you want to make sure that you are providing specific symptomatic details to the patient to choose from. When they say, I don't know, it hurts. Is it an aching feeling? Is it a stabbing feeling? And you want to ask them to point to that location. So we're going to talk about that a little more in the next slide. But what you can see on your screen here is depictions of where an infarct physically impacts the heart. So if it's anterolateral, that's on the front and the side of the heart, posterior, inferior, apical, posterior lateral, anteroseptal. So you can see all of those spots that have kind of that dark purple are showing where the infarct is. So again, as I mentioned, when you're asking the patient about chest pain, and this is certainly something you can do from the outpatient setting, even if you know you're going to send the patient to the ER, you're going to need some information about the patient as the nurse practitioner. So you want to think back to old cards, right? You want to think about the onset of it, the location, the duration, the characteristics, aggravating and alleviating factors. You need to know the timing with it. So you're asking your patient to point to the area of pain and describe the features of their symptoms. Clarifying, is the pain related to exertion? What kind of activities bring on the pain? How intense is the pain on a scale of 1 to 10? Does the pain radiate anywhere, like the neck, the shoulder, the back, and down the arm? Someone who's telling you about tearing or ripping pain radiating to their back is very concerning of an acute unstable presentation, such as an aortic dissection, usually followed by acute instability where they are diaphoretic, their pulses are erratic, and then they code. When we're talking about symptoms associated, are they short of breath? Are they sweating? Do they have any associated palpitations or nausea? Does it ever wake them up at night? And what have they done to make it better? Another very important question to ask is, have you ever had anything like this before? Especially if it's a patient who's new to you in an acute setting, that is a very telling question. So have you ever had this before? Usually followed by, and what happened then? Did you have a diagnosis? What did they do for you? What made it better? So sources of chest pain can come from different parts of the heart. And we know that are going to cause different causes in terms of angina, pericarditis in the pericardium, aorta, and usually from aortic dissection, trachea or large bronchi. If they're feeling pain from that, usually due to bronchitis, whether that's viral or bacterial. Parietal pleural can cause pericarditis, pneumonia, pneumothorax, pleural effusion, pulmonary embolus, connective tissue disorders. The chest wall, including the skin, musculoskeletal, and neurologic systems, can cause costochondritis or herpes zoster. When you're thinking about the esophagus, we're talking about gastroesophageal reflux or esophageal spasm. And then extrathoracic structures such as the neck, gallbladder, and the stomach can come from cervical arthritis, biliary colic, or gastritis. Additionally, you can see on the left-hand side, when a patient is clutching their chest, that's considered Levine's sign, clutching over the sternum. That's usually the case in angina pectoris. With musculoskeletal pain, they may point to a very particular spot of where they're hurting on their chest. Whereas with heartburn, you may see a patient with their hand moving from their neck to the epigastrium and just continue to kind of rub that area. With syncope and similar disorders, these are again featured in your Bates textbook, but something that we need to consider when we are looking at the cardiovascular system is syncope cardiovascular in etiology? So there's vasovagal syncope, orthostatic hypotension that may cause it, syncope that can be due from cough, micturition syncope. And then on this slide here, what we can see is the cardiovascular disorders that are causing them from arrhythmias, aortic stenosis or hypertrophic cardiomyopathy, MI, massive PE, a disorder resembling syncope, so syncope-like syndromes, hypocapnia due to hyperventilation, hypoglycemia, and fainting from a conversion disorder, So with Holter monitors, we see that these are indicated for patients who are having chest pain that we may not have a good cause for. So Holter monitors are, again, non-invasive and very relatively inexpensive of a test. However, the patient does need to be able to wear this and be compliant with this for anywhere from 24 hours to sometimes a 72-hour, all the way up to a 7-day Holter. So they detect cardiac dysrhythmias that occur during normal activities and correlate them with the symptoms experienced by the patient. And usually there's a button that can be pressed by the patient so that they can indicate the symptoms that they're feeling, and it will go ahead and trigger the monitor to put an asterisk next to it so it can be reviewed. It detects sporadic arrhythmias missed by exercise or resting ECG, evaluates chest pain, palpitations, dizziness, and syncope, and evaluates activity intolerance associated with imbalance of oxygen supply and demand. It also can monitor the effectiveness of an antiarrhythmic drug, especially a pacemaker if the patient has that, and monitors for ischemia and dysrhythmias following MI or heart surgery before changing rehab and other therapeutic regimens. So with cardiac and vascular referrals and special tests, we see exercise-induced stress tests. We also see chemically induced stress tests, and then oftentimes an echo, so we can get the ejection fraction of the heart. So the evidence is diffuse, and where do you go to look for the evidence? And you really want to think about who are the people that are the main stakeholders in cardiac and vascular. So we're talking about the American Heart Association, the American College of Cardiology. The CDC even has their own recommendations. And so you can see these all come from your Bates textbook. Again, there are up-to-date guidelines that get posted every year. So you want to be very sure that you are looking for the most up-to-date guidelines, but these are great resources. And again, this is from box 1617 of your textbook. So risk factor reduction challenges, when we are thinking about what are the risks to our patient and what's our goal. When we look at family history of premature cardiovascular disease, we want to know our patient's risk. So how do we do that? We ask about the family history. With cigarette smoking, we need to have the patient's cessation of smoking or continued abstinence if they've never started. And we do that again by asking the patient their diet, physical inactivity, history of obesity, family history and personal history of hypertension and management, dyslipidemias, diabetes, atrial fibrillation. So healthy behaviors that we see attributed to risk factor reduction are BMI less than 25, history of non-smoking, good physical activity, meaning usually 3 to 5 days a week of at least 30 minutes of activity, and a healthy diet. And again, a diet is going to vary based on a patient's religious preferences, as well as their caloric needs. However, we are seeing that vegetarian diets that are low in animal protein, in fatty foods, saturated fats, those greases, those are all dietary choices that we want to suggest towards our patient. And the health factors as a result, when we are measuring objective findings, are a total cholesterol level less than 200, blood pressure target range of less than 120 systolically and diastolically 80, and then a fasting blood glucose of less than 100. Again, those are from Bates. Now, when we look at risk factors and risk estimations, this is a very good tool to use in the primary care setting. And so by plugging in this information about the patient, you can understand if your patient is low risk, borderline, intermediate, or high risk. So this includes the patient's age, their gender, their race, their blood pressure readings, their most recent total cholesterol, HDL, and LDL, And then some factors about the patient, such as if they have a history of diabetes, if they are a smoker now, former, or never, if they are currently on hypertensive treatment, on a statin, or on aspirin therapy. And so by using this tool, you can gauge, again, what is the risk to the patient, a lot of which are by demographics, and then those factors that patients can change, those modifiable factors, by their diet, exercise. The American College of Cardiology and American Heart Association does give cholesterol guidelines. These are from 2018, again, featured in your book. And you can see this algorithmic approach on patients of different ages and really where in the risk category patients fall based on their cholesterol. We also have to consider that patients are going to have chronic issues with cardiovascular. And so in looking at systolic heart failure versus diastolic heart failure and the normal heart, you can have a depiction here of exactly what the anatomy on these structures look like. And when we are escalating care, so specifically if we are concerned about a patient that potentially has pericarditis or endocarditis, again, depicted in these visuals here for you. Those may be from infectious or inflammatory etiology. It may be from a rheumatological condition, bacterial, IV drug use. So you need to know the risk factors that cause these specific conditions in thinking about your FNP scope. And then again, just a great visual to show you various heart defects that may affect your patients, that you're coming to know this patient and maybe they didn't know about their heart defect, but they're having symptoms and you're working them up only to find one of these. So a great visual of atrial septal defect when you're looking at PDA, tetralogy of Fallot, a lot of those that are affecting pediatrics on the bottom, coarctation of the aorta. So again, just a review here for you. Now, when we get to the rubric itself, again, we talk about what are the things that need to happen in every video. We need to make sure appearance-wise that you are wearing your lab coat once you've received it from immersion, that you are in business and professional clothing with no scrubs. You're getting 4 points on those alone. Autonomy, that you are performing it independently. You've consented your patient, which is mandatory. Again, that you are getting verbal consent at the beginning of the video, that you are speaking to your patient about the purpose of the recording, that it will be uploaded to YouTube as unlisted for your instructor to grade. With communication, that you're continuously verbalizing the steps of the examination to the patient and to your instructor throughout your exam. And then flow and positioning, that you're not frequently starting and stopping, that you're not pausing for extended times in your video, and you're not frequently changing the position of your patient. With cardiovascular exam rubrics, so when it comes to the first step, you are verbalizing only that you would obtain the blood pressure of the patient. In each arm, in order to most accurately assess that, you would do that in 2 positions, in a sitting and sitting and supine. And that is the most accurate way to obtain a thorough blood pressure. You also want to make sure that the patient has the appropriate cuff size for their body habitus. Next on the rubric are the neck vessels. So demonstration of assessing the vessels of the neck. So by first placing the patient in a supine position, usually with a pillow behind their head for support of the neck, or in a slightly upright position, you want to measure JVP while the patient is lying at approximately 30 to 45 degrees, and verbalize the actual measurement using the ruler, which you can see depicted right here, figure 1620 on page 510. When assessing the carotid arteries, you want to palpate each artery one at a time to not occlude the flow and verbalize those pulse findings. You do need to make sure outside of just assessing it that you are verbalizing what the pulse feels like. Auscultating over each side is also important, and you must perform and not only verbalize that. When that is being visualized, you can see on page 511 and figure 1621 and what those findings may signify. When it comes to visual inspection of the chest and trunk, you need to visualize and verbalize the findings of the sternum and the chest wall, and that does not involve exposing your patient. If your patient does feel comfortable as a female being in a sports bra or a tank top, that's preferred. If your male patient feels comfortable with their shirt off, as this video is unlisted and that link is only available to those you provide it to, that's wonderful. But if they do not feel comfortable, please do not expose your patient for the purposes of this exam. However, you would verbalize the appropriate technique in an exam room with a patient. So you're going to also inspect the anterior chest wall for the apical impulse, if visibly pulsatile. So Bates recommends the best way to do a precordial examination of the patient is by you standing at the patient's right side and having them tilt or roll to their left side, where you then are going to feel on that left hand apical impulse. You're going to inspect for precordial pulsations and verbalize if they are visible on the patient's chest wall as well. With palpation, palpating over the PMI and telling us exactly where that is and describing it. Palpating throughout the chest wall for any thrills, heaves, or lifts in all of those auscultatory areas, and then palpating over the anatomical landmark of the abdominal aorta and verbalizing the findings. So you can see in the figure on your right lower screen here, the right second intercostal space is the aortic, the left second intercostal space is pulmonic. You've got Erb's point just at that third, the right ventricular area, the left sternal border, and the left ventricular area, the apex. So you've got aortic, pulmonic, tricuspid, Erb's point, and your mitral valves. With auscultation, again, you're assessing over those areas I just mentioned with the diaphragm and the bell of your stethoscope. You need to listen for physiologic splitting of S2 and verbalize the reason for splitting or the potential reason. We don't expect that you're hearing this. And when it is best heard, which is upon inspiration of the patient. There is an idea of where to look in your book to find that information. Auscultating over the abdominal aorta and verbalizing the findings as well. So in box 16.7, it discusses what are the uses of the bell and the diaphragm, and when would you prefer to use one versus the other, what you're looking for. So I'll leave that for you to pause and take a look at if you're interested. Again, it is in your text. So with your cardiovascular exam, this is a depiction of auscultating on the left lateral side, as I mentioned, as well in a sitting position, and auscultating for mitral stenosis versus aortic regurgitation. So while we are on those topics, we're going to talk for just a moment about murmurs. So murmurs can be systolic, they can be diastolic. The valves have malfunction when they are contracting in a systolic murmur. And in diastolic murmurs, the valves have malfunction in filling. So when you are thinking about a murmur, you need to first think about what's causing the condition and when is it best heard. When you are looking at systolic murmurs, these are mitral regurgitation, which is when it's a leaky valve, or aortic stenosis, when it's a stiff valve. Again, with diastolic, we have the opposite. So mitral stenosis is stiff and aortic regurgitation or a leaky valve. When it comes to boards, they do love to ask questions about which murmur, usually based on presenting you with the characteristics of the murmur. And so they'll ask, is this murmur systolic or diastolic based on that? They may ask you to even identify the murmur just on description and characteristics alone. A way that I remembered it in school is that MR and AS are systolic and MS and AR are diastolic. And so there are several acronyms that you can look up to figure that out and start to memorize those patterns. When it comes to grading a systolic murmur, there are 6 degrees. So 6 being the absolute loudest, can hear it from the door almost, and 1 being very barely audible to a highly detected stethoscope where you may have otherwise not picked it up at all. So you can see those depictions there. Starting at a grade 4 out of 6 is when an associated thrill is involved in the murmur as well. And then more about murmurs, again, just another great visual here for you when you're thinking about where it affects the patient's heart. And then congenital defects showing a septal murmur, stiff ventricles with hypertrophic cardiomyopathy, and stretch out ventricles with dilated cardiomyopathy. With cardiovascular exams, we also have to think about peripheral examination. And again, this is part of your rubric. So observing all 4 extremities for the patient's color, warmth, presence of any abnormalities, and those may include edema, varicose veins, or shunts. You're then going to palpate over each of these pulse points. So radial, brachial, femoral, popliteal, dorsalis pedis, and posterior tibial pulses. With the femoral, you're going to also want to auscultate with the bell and the diaphragm, as well as palpate. Checking the fingers and toes. So you're going to visually look, what is the patient's capillary refill? Is there any evidence of clubbing, cyanosis, splinter hemorrhages, and tarring? Those last four are things that we do want to hear when you are performing your examination and visualization of the patient. With venous circulation, we're thinking about superficial veins and deep veins. And so specifically the conditions that can affect the patient may be a contusion to the leg. And does that affect a deep vein? And that is the concerning finding of a DVT, or a deep venous thrombosis. So when we talk about venous abnormalities, we are thinking, what is going on with the patient's venous system? And specifically, this is looking at the lower extremities. So we have telangiectasis, we have varicose veins, edema, venous leg ulcerations. And so when we're talking about peripheral edema, that can be from chronic venous insufficiency. It could be from a condition causing lymphedema or pitting edema itself. And then another thing to be very mindful of are the differences of PAD, or peripheral artery disease, versus PVD, or peripheral venous disease. And so you can see the contrasting factors here in terms of symptoms, as well as important things to remember. So usually with PAD, we see when the patient's legs dangle or hang, that causes the condition, or that improves, whereas elevation of the legs, or that peripheral venous disease, improves. With venous thrombosis and the risk factors of VTE, those involve the patient's family history, prolonged immobilization, potentially greater than 3 days, surgery within the past 4 weeks, a trauma to the affected area, pregnancy, certainly placing a patient at a higher risk, previous history of DVT or PE, malignancy or cancer, hormone use, specifically estrogen, the patient's age being greater than 50, oxygen saturation lower than 95%, or hemoptysis reported by the patient. So I have a few risk stratification factors here for you to consider when you are looking at the patient. So if you're concerned about a potential DVT or PE, there are your Wells criteria, which are for PE and DVT, and the PERC rule. And so these are using those factors that you can learn very quickly about the patient by asking them questions and obtaining those vitals, right? So is the patient, again, is their age a factor? Heart rate and oxygen level. Do you see any unilateral swelling of the leg or any hemoptysis reported? Has there been any recent surgery, prior history of DVT or PE, or hormone use? These do help make those concerning factors put into a bigger picture of how concerned do I need to be about this patient and their risk for PE or DVT. So when you are doing your write-up or documentation on cardiovascular this week, it should be in an APA format, which means that you do need it to be neatly organized with headers. The spelling and grammar should be appropriate with no typos or grammatical errors. And you need to make sure you are using medical terminology, so anatomic landmarks and appropriate terminology to describe the assessment techniques. The content does need to be thorough of the objective findings only. You are not including subjective. There is no ID, CC, HPI review of systems. It is specifically your objective findings. So in order to earn full points, you followed all of those directions, and you can see a concise example, not a example for this documentation, but a concise example of what a clinician working in the setting and assessing patient cardiovascular health may involve. Now we are on to pulmonary. So when we are looking at the anterior and posterior thorax, we need to first think about the ribs, those protective structures of our lungs. And so you can see here all the way down to the 12th rib, the sternal angle, or the angle of Lewis, and the suprasternal notch on your left-hand side of the screen. And then the posterior aspect of the ribs, again, counted down to those 12th ribs. When you are looking at the center and the bottom of the screen, you can see different areas of rib fracture there. And then specifically thinking about our lung fields and where we need to auscultate is going to involve all of the lobes in different locations. So we can hear this anteriorly, we can hear this posteriorly and laterally. When we're interpreting a chest x-ray, we need to think about what are the structures and what are the findings. So specifically, you need to know the anatomy of what you are looking at first. You need to know exactly where those lobes would be contained on an anterior film. And then looking at the ribs themselves, looking at the heart as well, even though we're talking about pulmonary, does there appear to be cardiomegaly? When we are thinking about pulmonary differentials, there are several potentials. Again, this is not a comprehensive list, but these do give you an idea of some things that you may see again in the primary care setting or in an urgent or emergent setting, as well as managing these chronic conditions. So a great idea to consider that all of these conditions listed may actually have pulmonary manifestations. And then we need to consider, when is it outside of our scope? When do we need to escalate care? So if the patient is having findings concerning of pneumothorax, based on our auscultation and the history we're obtaining from the patient, potential for pulmonary embolism. Again, I showed you those risk stratification scores. The inability to speak in full sentences, their use of accessory muscles showing distress, cyanosis or pallor, diaphoresis, or evidence of low oxygen saturation. So I'm going to spend just a moment speaking about asthma, as it's something we commonly see, and it is quite complex in terms of an algorithmic-like approach. And so clinical practice guidelines, or the GINA asthma guidelines, really are one of the guiding factors on how we treat asthma. So you can see this preferred track versus alternative. And again, a great visual of different triggers which may affect your patient's asthma. Clinical practice guidelines, and so this is taken directly from GINA, or that Global Initiative for Asthma. So in talking about steps 1 and 2, step 3, step 4, step 5, a great way to study for boards when you are looking at this is to understand what is an ICS, or an inhaled corticosteroid. What is your medium dose maintenance? And so boards are never transparent about specifically asking one thing. You need to have a good understanding of the concept and how to apply it to the patient. Asthma action plans are something that you need to be aware of, especially as you're about to go into the clinical setting next term, and thinking about what is the right thing for this patient. So there is the normal mode, the asthma flare-up, and the asthma emergency. And you can see these in 2 different formats here, just to give you some different ideas of what this may look like. This is especially beneficial for children that are going to school and when they are allowed to use their rescue medication, or if they're using a routine medication. So finally, we'll talk just briefly about the chest and breast, and really how this affects us is our ability to know these structures, where to palpate, and what we're looking for. So you have your venous structures on your left-hand side of your screen. You have the breast divvied up into quadrants, as well as the tail of Spence. And anytime you are performing a breast examination on the patient, you want to think about a breast in the form of a clock. You want to consider 12 o'clock at the very top, or north, 6 o'clock at the very bottom, or south, and then east and west is that 3 and 9 o'clock spectrum. So when you're considering the quadrants, you really want to talk about the breast, whether you are performing an examination on a patient at a general visit, working in a gynecologic office, whatever that may be. If you do feel any abnormality, you want to be specific, especially if you're sending the patient for an ultrasound or a mammogram, usually both, for diagnostic purposes. There are also several lymph nodes found within the breast area and the chest wall. And so those are something we need to consider. Is it inflammatory based? Is it infectious? Or could it in fact be a malignancy? Breast cancer screening guidelines come from several different areas. So the U.S. Preventative Services Task Force is the average risk for women. When we are thinking about the American Cancer Society and ACOG, they also give their own recommendations on when mammogram is appropriate versus clinical breast exam and breast self-exam. So previously, breast self-examinations were recommended to be performed by women monthly, usually after their menstrual cycle, especially if a patient is postmenopausal and no longer getting a cycle, to have that on the same day every month. It is something we can still educate our patients about. However, they're seeing that there's not enough evidence to support that is the best detection for a woman to talk to their clinician. So we do recommend annual screenings with a patient's provider in terms of a clinical breast examination or palpation, and then escalating to mammogram or ultrasound based on the patient's risk factors and age. So on the left lower hand side of the screen here, you can see a normal breast at the very corner, and then the development of a mass, which gets progressively bigger until the last picture on the most right-hand side of the screen, and then what cancerous cells may look like. So now on to the rubric portion of lung and thorax. We're talking about inspection. So physically looking at the chest wall, again, keeping your patient appropriately covered as they wish, to visualize both anteriorly and posteriorly while the patient is seated or standing. And you're going to be looking for that AP ratio. You also want to visualize any chest wall deformities and verbalize that on your video. You're going to verbalize the patient's respiratory effort and their movement. So you would say something such as, I'm looking and I do not see that the patient is having any labored breathing, tachypnic. There's no sternal retractions or use of accessory muscles. Those show that the patient has normal respiratory effort and gives detailed findings as to why those abnormal findings are not being seen. Inspecting the patient's nails. So specifically, I'm looking at the circulation of the digits in the nails. I do not see any evidence of clubbing or cyanosis while I'm looking. With the lung and thorax examination, you're also going to be performing palpation. So respiratory excursion with anterior and posterior fields, and the extent and symmetry of that, as you can see depicted. Tactile fremitus, anterior and posterior, and that's when the patient is saying 99 as you are feeling and palpating over the chest wall. And then costochondral tenderness. So you're going to be palpating with kind of the palms of your hand as well as the pads of your fingers to palpate if the patient is having any tenderness over any anterior of their chest wall. With percussion, we're doing that bilaterally. So a side-to-side comparison, and you can see here in about just the middle of the screen exactly the pattern and the fashion of what bilateral and side-to-side looks like when we talk about percussion. The technique is middle finger on top of the middle finger. So basically a middle finger on top of a middle finger when you are palpating, or excuse me, when you are percussing. With percussion being done in all fields, anterior and posterior, and then what the abnormal findings may be with percussion. So hyperresonance versus dullness, a unilateral hyperresonance. And so I will leave you there to review those again directly from your book. Diaphragmatic excursion, so that's being done posteriorly. You are looking bilaterally when you are performing diaphragmatic excursion, and again, the findings of that. So please refer back to your Bates textbook on how to perform diaphragmatic excursion appropriately. As a review, when we are doing auscultation, we should be doing it in a ladder fashion, anterior, posterior, lateral, as well as the apices to make sure that we are hearing all fields appropriately. With special tests, you are going to perform one of the following. You could do bronchophony, egophony, or whispered pectoriloquy. Explain those findings to us, as well as what would a positive finding demonstrate. You are getting those points again just for doing these areas that are mandatory on your video, which is your consent of the patient. You should be having clear autonomy, which means you're performing independently without any use of notes, communicating those findings with your patient and your instructor with good flow and positioning, not frequently starting or stopping. And your appearance should be with your lab coat on as well as professional dress. Your documentation, again, is just a write-up for this week. So objective findings. Something that is frequently asked is, can I put these videos together? And the answer to that is no. They need to be 2 separate videos, as well as 2 separate assignments submitted for documentation purposes. Your instructor will then average those together in the gradebook to give you your earned score for the week. So that's all I have for you this week in terms of cardiovascular, the peripheral vascular system, your lung and thorax, and chest and breast. Your Bates book is always your best reference. Make sure you are going there to look up any ideas and techniques that you need to have a review on. Please make sure you are also completing your sync summary session this week and submitting it next week by Monday night, so that you are making sure you are getting all of the credit that you deserve for this assignment. If you have any questions, please reach out to your grading instructor, and I wish you all the best in week 5.